right? The prevalence of obesity and diabetes would be very significant. So this is just something to think about as we pursue coverage options or as we make a case for expanded coverage for Medicaid in the state of Louisiana. Next, let's talk about state employees. So there are about 62,000 employees of the state government in Louisiana, with about 35% obesity prevalence rate. You can do the math, and there are about 21,700 patients who are currently eligible for bariatric surgery but do not have coverage. So let's think about that number a bit again. Like there's 21,000, almost 22,000 patients who are out there who do not have coverage. And of course, Joe Naglowski is going to talk more about how we can work with our patient advocates to make a case for coverage. And this number is definitely one that we've got to think about and think about the number of patients who are currently not meeting their medical necessity needs. So let's do a deep dive into the coverage options for the state employees. And there are many of these plans which are typically eligible for the state employees. And I've been through all of those plans. And a common exclusion criteria that's listed on each one of these plans is what you can see on the right-hand side of the slide. So it says that regardless of the claim of medical necessity, benefits are excluded for services, surgeries, supplies, treatment, or expenses related to, first, weight reduction programs. Second, bariatric surgery procedures, including but not limited to Roux-en-Y gastric bypass, lap banding, sleeve gastrectomy, and duodenal switch with biliopancreatic diversion. So, and then the third piece is removal of excess fat or skin or services at a health spa or a similar facility. The third piece is what kind of partly annoys me a bit, is that we are clubbing bariatric surgery, which is a well-established therapeutic procedure, along with liposuction type of procedures, which are done at a health spa, right? And also, there's no coverage for weight reduction programs. We know that medical weight reduction programs are an important first step in the journey of a bariatric patient. So this exclusion criteria is something that we all need to think a lot about and see how we can make a case, how we can make an evidence-based case in fighting against these exclusions. There has been some positive movement, though, and this is the Senate bill in the state of Louisiana, which would provide coverage for the state employees. And at this stage, perhaps Dr. Schauer could talk more about this at a later time. Of course, there hasn't been much movement, and I believe there will be some movement on this, at least on the administrative side. So there is some progress that's being made on this front, and I think we need to actively work towards making an evidence-based case again to ensure that these programs, these legislations or administrative actions do go through, and you provide coverage to those 22,000 state employees. Next, the third big opportunity is about state health exchanges, right? There are about 88,000 enrollees in the state health exchange of Louisiana. And if you do the math again, there are about 31,000 state health exchange enrollees who are currently eligible for bariatric surgery, but again, do not have coverage. And of course, the picture nationally is quite challenging as well, with 27 states not providing coverage for for bariatric surgery in their exchange programs. So this specifically, again, gets to Louisiana. So you can look at the 2017 benchmark plan. And there again, there is no mention of bariatric surgery. And in fact, bariatric surgery and weight loss programs are specifically called out as therapeutic options that are not covered. Some positive news, though a very minor one, is that dietitian visits, diabetes education, sleep studies are covered. But of course, weight loss programs and bariatric surgery is not covered. There's a way to go about addressing it. In 2019, CMS made it easier for states to change their benchmark plans. A legislative process is no longer required. We can do it through a regulatory process. And there is more information available on the CMS website on how to go about making these regulatory changes. So in conclusion, there are about 52,578 patients who are waiting for coverage for bariatric surgery for this life-extending therapy. And we've got to work towards ensuring that each one of them have access to bariatric surgery. So with that, I'll conclude my talk and turn it over to the next presenter. Thank you.
Great. Thanks so much, Santosh. That was a really wonderful overview. We've got our work cut out for us, but there is some positive news there. So we have to just keep pushing forward. So to that end, I'd like to reintroduce Peter Lundberg. Peter is the current chair of the Access of Care Committee in Louisiana, and he's going to kind of summarize some of the initiatives that have been put forth in the last few years, within this chapter. So Peter, please take it away. Oh, before I forget, please don't forget to submit any questions either through the Q&A. You can also submit questions through the chat line as well. Take it away, Peter.
Dr. Schauer, thank you very much. I'm going to share my screen here. Let's see. All right. Briefly, thank you, Phil, and thank you everybody else for joining. I have been on the Access to Care Committee here in Louisiana for the last little over 2 years. I was set to give it up to Dr. Guest-Chassin here on the chat as well, but COVID kind of got in the way of that. I want to say it's been pretty awesome being a part of this. It's both humbling and very empowering to see the kind of change that Dr. Northrup and other members of the committee have accomplished, and really gotten me thinking broadly about what can be accomplished here in Louisiana, even as a young surgeon. Just for a brief overview on the Access to Care Committee, there are 7 regional representatives, and each state has its own individual representative, for which I am of Louisiana. And aside from the general objectives to increase awareness of access issues throughout the U.S., we focus a lot on identifying reasonable targets for progress in the short, mid, and long term. Short term include a lot of things you might see as members of ASMBS, like increasing member participation and utilization of resources. Those aforementioned links that we hope people follow to raise awareness about CMS changes, et cetera, are a big part of that. Also monitoring insurance policy changes like what Dr. Northrup and Dr. Hutter are recently involved in are huge as well. But in the long term, it's really about those legislative efforts to make really substantive change over a long period of time. In Louisiana, kind of recent relevant history goes back to a pilot study by Ethicon and Pennington that ranged from 2003 to 2010, which looked at the cost effectiveness of gastric bypass versus medical management. And this looked at about almost 1,000 state employees, 39 of which received surgery. So it's a bit of a weighted study, but it did show an average weight loss of almost 100 pounds 4 years post-surgery, excess weight loss of 61% at that time, and a reduction of medical costs at 4 years after surgery that continued through the conclusion of the study. While there was an obvious peak at year 1 related to the cost of surgery itself, this was a great study within Louisiana showing that over time, the cost per patients did go down. And this is just looking at the medical costs and not the improvement in comorbidities. More recent, and that pilot study was used to fuel a lot of efforts by some of my predecessors and other people on this webinar as well, that led to a bill being introduced by Senator David Heitmeyer in 2015 that stipulated that all Louisiana Medicaid plans cover bariatric surgery and the necessary preoperative requirements, and that surgery be performed at an MBSA QIP accredited center. Now, my understanding is that there were efforts made at this time to then extend that coverage to state employees as well. However, that the reticence to reimburse beyond Medicaid rates stalled at the Office of Group Benefits, and ultimately led to the current situation that we've seen in the Dr. Northup and Santosh's slides, detailing how Louisiana still does not have state coverage, coverage for bariatric services for state employees. The next step in the legislation due to be introduced by Senator Regina Barrow, which was due to be presented earlier this year, and we had a lot of momentum for it, but obviously got derailed by the pandemic. States that it requires the state office of group benefits to cover bariatric surgery techniques for the treatment of severe obesity. And my presentation here is brief, and this is kind of where we stand. But I wanted to reflect on what this means, statewide for Louisianans, because while state employees, that only covers less than 100,000 patients or individuals. Frequently, the extension of coverage to state employees is seen as a bellwether for the subsequent extension of benefits to other large employees in the state. A lot of people on this chat, including myself, we perform bariatric surgery or do weight loss services at institutions that do not cover their employees, LCMC included among them. Places like Ochsner, LSU, Tulane have variably attempted to cover their employees, but frequently sided against it. And the chain between state coverage employees or coverage of state employees and coverage for large employers, including in the medical field, is not a direct line. But in the past and in other states, what I've learned is that getting coverage for state employees is a very important domino in that chain. I'm going to reclaim some time for the webinar here. This is really all that I got, and really defer to some of the incredible guys that we got on this webinar as well. It's been pretty exciting going through this, and I look forward to building on the momentum that we're getting here, and really trying to advocate for change in the future legislative sessions. With that, Phil, thank you so much.
Phil, I think you're muted.
On mute.
Thank you. Peter, I said a lot of nice things about you. Now you can't hear them. No, great job, Peter. Thanks for all your work and all the surgeons who preceded you trying to improve, access. I will point out, Peter, that, you and I tried or attempted to invite Dr. Barrow to join us tonight. I think she was had a conflict, but perhaps we can bring her maybe at a subsequent meeting, perhaps next year early, to talk about this bill that she introduced, and maybe Lieutenant Governor Nungesser might be able to make some comments about that when he talks as well. So our next speaker, and I'm really pleased that he's able to join us, Dr. Marcus Bachhuber. Dr. Bachhuber is the Chief Medical Officer of Medicaid in Louisiana, and he's going to tell us about the current policy, and I'm sure there'll be plenty of questions for him. So Marcus, again, thank you so much for joining us.
Thank you. Yeah, thank you for having me, Dr. Starr. Thank you for the invitation, and thank you to ASMBS for having this meeting. Today, or this evening, I'd like to talk about our coverage of bariatric surgery in Louisiana State Medicaid. So in Louisiana Medicaid, we cover about 1.7 million members, and I serve as the Chief Medical Officer for the state agency, and I'm an internist by training, so I'm definitely well acquainted with problems caused by obesity, metabolic conditions, cardiovascular disease, diabetes. I mean, that's 90% of my clinical time. So we have 1.7 million members overall in the state, and in Louisiana we have a managed Medicaid program, and by that I mean that 90% of people actually receive their coverage directly through one of the 5 managed care plans, and the state pays premiums for those individuals to the plans. And so that's the most common model of Medicaid in the country. I think almost all states have at least some version of managed care, with a couple of exceptions. And the way that works is the state agency, really sets the floor for what those plans have to cover. The state agency's program, called the Fee-for-Service program, insures directly about 10% of Medicaid members in Louisiana, and it sets the minimum benefit package for those who are covered by the managed care plans. The managed care plans can cover more things. They can reimburse more than the state does. They can cover more types of individuals. They can cover more units of some service or some device, but they're tied to us as the minimum. And so what I'm going to talk to you today about is our process for revising bariatric surgery coverage in Medicaid. So recently, our program has embarked on a project to really take a look and modernize our coverage policies to align with national best practices and evidence-based standards. This is a pretty large undertaking. We estimate it'll take about 2 years from start to finish. We're maybe 3 to 6 months into it. We've so far identified dozens of clinical services, that need to be updated. And then once identified, we research and review some of these policies. So one of the big first steps is identifying subject matter experts, getting feedback from them. And so special thanks to Dr. Schauer and Dr. Michael Cook from UMC for really raising this to my attention. Dr. Cook, I think we talked about this. I was thinking about it today, probably 1.5 years ago. And I told you we would figure it out, and we did. It just took a little bit longer than I was hoping, but we got there. So we work with experts in the field to understand what the national best practices are, the evidence-based standards, and then we look at what the other coverage policies are for other Medicaid states, for Medicare, for commercial plans, just for all other insurers. Then we post the policy for public, we revise the policy, develop it, post it for public comment and feedback. And then once it's accepted, we compose and distribute updates to providers and to our managed care plans. And then finally publish the new content in our provider and service manuals. So why was the bariatric policy flagged for updating? So it was outdated and not really evidence-based anymore. There were several criteria that were subjective and inconsistently interpreted. There was some potentially problematic language around mental health and substance use disorders. That was not the intention, but it could be read in that way, which is an issue. And it wasn't particularly patient-centered. So our previous policy, I'm going to go through a couple of slides highlighting some of the issues that we wanted to address. In our previous policy, we required confirmatory evidence of comorbid conditions. So it's a question is, well, what evidence? And then we also required photographs to be submitted with a request for consideration of surgery. And looking, historically, that was fairly common among state Medicaid programs, and I think even Medicare potentially at one point, and some commercial insurers that we found, but really not appropriate in 2020. We required that folks be a minimum of 16 years of age. So we know that, or as I understand, there's data that it can benefit people who are younger. Had to have a body mass index greater than 40, which I think at the time was the eligibility, but that's changed. This one caused a lot of issues with interpretation, have at least 3 failed efforts at medical therapy and experiencing the complications of extreme obesity. So the 3 failed efforts, what does that mean? Medical therapy, what is that? Is that exercise? Is that medication? And then complications of extreme obesity. Extreme obesity is not really a medical term, so it's difficult to demonstrate that. Then have obesity-related conditions, which put someone at a very high risk for morbidity and mortality. Well, what level of risk, what conditions? Not have a major psychiatric diagnosis. Again, it's less about the diagnosis than whether the person can adhere to the follow-up regimen, can understand their treatment, consent to the surgery, not currently be abusing alcohol or other substances. Again, it's more about what, can the person understand and adhere and consent to the surgery than it is about their use of other things. I mean, there's plenty of people who wouldn't have a mental illness, would never, don't use alcohol or other drugs, but would not be capable of following through with bariatric surgery. And so it's not, that's more of the issue than those 2 things. And so we worked together to make some revisions, and I won't go through all of it, but you can read here, and I'm happy to send out these slides after the presentation. But we really tried to align it with best practices out there and guidelines out there to ensure that, because we cover it, we felt it extremely important to cover it appropriately. That probably goes without saying. So we offer coverage for adults with a BMI of 40 or greater, 35 or greater with 1 or more comorbidities, and then a BMI of 30 to 34.9 with type 2 diabetes that's uncontrolled despite treatment. We also removed mention of photographs and removed a call out of mental health and substance use disorders for the reasons mentioned. For children, we felt it was important to add more specificity to our coverage for folks under 18. So we added some criteria for 13 through 17 listed here, which we got from national guidelines. And then there's also a requirement for evaluating medical necessity for people under the age of 13. So under federal regulations, Medicaid has to cover all services that are medically necessary for individuals under the age of 20. And so that's a core component of the Medicaid program. And so we wanted to make sure that our coverage of bariatric surgery aligned with that requirement. So we have this policy currently posted for public comment, and the link is here, which we can send out, or I'm happy to send out, send to you, Dr. Schauer, to send out if folks are interested. You can comment on it, and we're happy to take any comments and address it in our published policy. And the plan is for this to be effective January 1st, 2021. And then just generally, we'll continue to review and update our clinical policies to align with current best practices. So again, just want to give a special thanks to Dr. Cook and Dr. Schauer for your help in donating your time to this effort. And I'd be happy to take any questions if there's time.
Okay, Marcus, that was excellent, and thank you for all the work that you're doing here. And that I have to say that update is really impressive. Marcus, do you have? Can you stay with us till the Q&A session, or if you have to go, and I would respect that, we might take a few questions right now. What do you prefer?
Oh, I'm happy to wait until the Q&A. I'm sorry, I didn't realize there was a Q&A at the end.
No, that's okay. Yeah, okay, very good. And I think there might be some questions about or related to the role of these, managed care organizations and their ability to, to add on requirements. There may also be questions related to just how and this may not be under your, jurisdiction, but how reimbursement is determined. So you might want to think about that for the Q&A. Okay, so thanks again. That was really fantastic. So our next speaker is our distinguished Lieutenant Governor of Louisiana. Lieutenant Governor Billy Nungesser. And Mr. Nungesser, I thank you so much for taking your time to spend with us. And we certainly appreciate you coming tonight. And you have a very unique story. We'd love to hear more about it. And particularly your ability and willingness to advocate for patients who are struggling with obesity. So thank you for joining us tonight.
No, thank you very much. And you don't need to thank me. I'm excited and passionately want to get involved. Real quickly, how I got to needing the surgery, I had sold my company and built a riding center in Plaquemines Parish for special needs kids. And when Katrina approached, I had nowhere to bring those specially trained horses. And me and my wife rode out Katrina 14 miles from the eye. After rescuing 34 people that lived with us for months and never seeing a politician, I made a dumb decision to run for parish president. 7 hurricanes and the oil spill later, I woke up one day and I gained 120 pounds. And until I had the surgery, I didn't realize how unhealthy I was. Within 4 months, I was off the medication, off the sleep machine, feeling like I did before I ran for office when I was in the best shape of my life. So as parish president, I met with Blue Cross and said, I'd like you to have 67 employees over 300 pounds. Many of them climb stairs to work these pumping stations, and they're a disaster waiting to happen. And they proceeded to tell me it wasn't a proven surgery. And I stopped them right there and I said, look, it worked here. I said, listen, I understand it's a business. If you'll cover those employees, and Plaquemines, I can't say we'll be with Blue Cross after I'm gone, but I'll be glad to sign a contract that if we would change carriers in 3 years, we'll give you 7/10 of the money back for the surgery. One, it's an investment in our employees. Two, I understand you pay for it up front. We change carriers, you lost your investment. And it would help if you're undercut when we bid out the insurance. If the parish has to write a check, it's a little insurance that we may stay with you. Whether lawyers began to work on whether we could do that or not. And of course, as lawyers always take forever, they waited me out of office. And then when I was no longer a parish president, they didn't want to talk to me. And then after an interview on TV about that story as lieutenant governor, I started talking to him again. And then we saw one too many storms as lieutenant governor. The governor started telling me, did you bring that to Baton Rouge with us? But I worked with Dr. Lavin, with some of the sheriffs. And I think the timing is right to pass legislation. And I'll say this, I will, if we decide that's the route to go and draft legislation, I will carry it around the state because I learned from my father, who was chief of staff to Governor Treen, you don't win any battles at the state capitol. If you don't go around the state and get those legislators to sign on why it's important to their people in their backyard, you only lose at the state capitol. So I really believe this is such an important issue, and the numbers speak for themselves. I need to get a few Republicans to sign on with the senator, and she is sick at home tonight. I did speak to her. I believe she has the COVID. So, but she is a dear friend, and I look forward to doing whatever it takes. You got to embarrass them into doing the right thing sometimes. And I think that we can do that and be successful. So with that, I'll stick around if anyone has any questions for me, or if you don't, I'm going to head back to Baton Rouge. But thank y'all. Please share my cell number with everyone. I will gladly go and make myself available anytime. And if I've got to help the senator with cleaning up some legislation that makes sense, I'll be glad to do that as well. So thank you.
Mr. Nungesser, thank you so much. And, first of all, please give our regards to Senator Barrow, and we hope that she has a very speedy recovery. And we very much appreciate her carrying the torch, for this bill. for the for OGB to add coverage for state employees for bariatric surgery. I think all the surgeons here probably have many examples of state employees. These are people that are career employees for the state of Louisiana who struggle with their weight but have no access to the surgery. And I have several examples myself who are excellent candidates, but they just don't have the coverage, and there's no effective other treatment for severe obesity than bariatric surgery. So we do appreciate you helping us and advocating, and perhaps you could share with us a better understanding. I know that you're in the executive branch of the government, and this bill goes through the legislative branch, and I don't know to what extent the executive branch would play a role.
Well, I think the best thing I can do is get the legislation and meet with legislators with those numbers and where we are, and get them to agree before we get into a debate on the House or the Senate floor that this is something we need to pass. And I passed a bill my first year as lieutenant governor. They said I would never pass, to allow me to do private-public partnerships at state parks, because the legislature don't like giving up control of any money. I went around the state and got every vote in the House and Senate except one. Mm-hmm. And it just made good sense, as this does. Now, I will tell you this, there's a lot of rumors out there that John Bell is being considered for ambassador to the Vatican. I think he's the only pro-life Democrat left. And if that would happen the end of next year, this would be an easy task, because I would serve out the remaining 3 years of his term, and I can assure you we would pass it then.
Wow.
But knowing that that's a possibility, I've had 11 legislators call and ask me, if the governor leaves, would I appoint them lieutenant governor to give them a leg up on running for the office. So I got a little bit more political stroke for the next year than a normal lieutenant governor would have. And as soon as we settle on the legislation, my job would be to go around and get commitments early on, and then host some breakfasts at my Pentagon apartment with legislators, with y'all, during the session, and then go testify about my story. And we owe it to the kids and the employees of this state not to let them down. And a vote against this would surely be letting those people down. And you got to leverage that with them. And because I'm a prime example, it saved my life, I believe that I can speak from experience, and I'm passionate about it. I've offered to pay for the surgery for 3 kids in bands that I felt so sorry for, because I could see how miserable they were. And it's ruined their childhood. So I'm passionate about getting this done. And in my opinion, failure is not an option. And I think with the COVID and people, I know I put on a few pounds through this. I think it's perfect time.
Wow. Well, I think I can speak for the entire Louisiana group of bariatric surgeons that we would certainly welcome your support, and your enthusiasm is contagious. I did want to mention that I had the opportunity to speak recently with Commissioner Darden, who tells me that there may be an administrative option to add bariatric surgery as a benefit, apart from the legislative route that Senator Barrow and yourself and others are trying to pursue. So that may be an option that that could be considered.
And if you're okay with it, I have a great working relationship with the governor. I gave him my word I would never speak ill of him in public, and I would never run against him 2 weeks after we got elected. And it's been the best decision I made for Louisiana. Some of my Republican friends don't think so, but we've been able to work together very closely. Where we disagree in private, and I will discuss it with him. I have breakfast with him every couple of weeks and let him know it's important to me. and I'll get back to the group and let you know his reaction as well.
Okay, well, that would be very much appreciated. Well, listen, Lieutenant Governor, we know that you're extremely busy. You have a very busy schedule. We appreciate all the time that you shared with us tonight. Thank you so much, and we will definitely be in touch soon.
Thank y'all so much. Have a great evening.
Thank you, sir.
Thank you. Thank you so much. Okay, wow, that was fantastic, wasn't it? That was really great. It's great to have an advocate like that, folks. Yeah. So,
Phil, if I could just say one thing,
please.
The Lieutenant Governor has been awesome to me, just as somebody who's been interested in the past, reaching out. He's called me on my phone. People in Dr. Lavin's group, as well as past surgeon champions like Dr. Rachel Moore and Michael Cook, and anybody who's tried to tackle this at the state level can speak to how awesome he is, and he will back it up. And I can tell you that we're going to be looking really carefully at Senator Barrow's recovery and reaching out and try to get the ball rolling on this as fast as possible.
Awesome. Awesome. And thanks to Tom Lavin for doing a good job on his surgery and taking good care of Billy Nungesser for sure. Pass that along to Tom if he's on tonight or if you see him. Okay. So now for our closing act is Joe Naglowski. And again, Joe is the CEO of an extremely important organization, Obesity Action Coalition. And let me tell you, they wield a lot of power. So Joe, please tell us on how we surgeons can work with our patients to improve advocacy.
Thanks, Phil. I appreciate the opportunity to be here tonight. And I actually don't feel as if I have to need to give my talk right now, because my talk's all about patients and surgeons partnering together. But I think Billy Nungesser proved that, right? How effective a patient story is. And in fact, you know, it wasn't too long ago that I was at the National Lieutenant Governors Association actually giving a talk just like this one. And, you know, I covered some of the data some of our previous speakers have had, and, you know, talked about what I wanted to do and all these actions with access. And then he basically, I was wrapping up and he goes, Joe, I need a little time. And I said, of course, Lieutenant Governor. And he gave his testimony, and shortly afterwards, the National Lieutenant Governors Association passed a resolution urging that we have comprehensive obesity care for people across the country. So I do think that, you know, it is just so very, very important that we include those with the lived experience in this conversation. And I want to be clear here, though, before I jump in the presentation, this doesn't mean we can just pass it off to your patients, right? This has to be a partnership between the healthcare professionals and your patients working together to try to deliver the best kind of care that we can and make sure people have access. I don't think one group will be successful doing it on its own. We need to work together on this. So I think most of you know me, so I'm not going to spend a lot of time other than on my disclosures. I'll just say I'm a very firm believer in the voice of the patient, right? So you'll see me put patients first, no matter what no matter what comes forward. But I'm going to spend a little time today, and hopefully all of you know about the OAC, but we are the patient advocacy organization. We've been around for 16 years, and yes, for 16 years, I've been working on this Office of Group Benefits issue in the state of Louisiana, trying to improve coverage. I've been to the Capitol many times, and so have our members. You know, working with all the folks that have been named earlier, and seen this process, and just recognize that. I'll just say that things move slow when it comes to policymaking, and just frankly, they move a little slower than most places in Louisiana. So hopefully, and I think I'm equally excited as everyone else that we're seeing significant progress, and we'll see significant progress this year. You know, I think, and again, I've said this already, but I'll just emphasize it again. Your patient voices are important, so include them, right? I don't think any of this can be done. I don't think you should do any meeting without someone with a lived experience there and a healthcare professional to guide through that conversation. And I know a lot of you use your patient advocates in different ways. You use them for marketing, you use them in other activities. But I think the one thing that's very important, that when you use a patient advocate, is that you must recognize that you have to stand up for them then, especially if we put them in these situations of politics. You know, politics can get a little ugly, as all of us who follow the news can see these days, and someone might just be attacked because they shared their personal story. So the other thing I would encourage is if you're having your patients share their stories, then you and your team and everyone you know needs to be ready to stand up to defend them against this stigma that exists around obesity. And I think all of you realize this. It's not only a stigma about obesity, right? It's a stigma about needing help for your obesity, about needing bariatric surgery. I know some of you as surgeons face that stigma as well, but I think it's important to recognize that there are unfortunately parts of the public that are going to push back on this. And we even see that around COVID, right? We obviously know that obesity causes significantly worse outcomes if you develop COVID. And even now, as we're talking about vaccine distribution, we saw some pushback just in the last couple of days about saying, well, why are we prioritizing people with obesity because they did this to themselves? And that's obviously not understanding the science or the complexity of this issue. But the other thing that I'll tell you about the patient voice is that it is what policymakers remember. Frankly, I don't mean to insult you guys, but when we go to do legislative visits, and I go back to follow up, they actually never are saying, hey, how's Dr. So-and-so doing? They're actually saying, hey, that patient you introduced me to, did they get their procedure done, or how are they doing? Are they continuing their improvement in health, right, kind of thing? And so just keep in mind that patient champion is important. And by the way, don't be afraid to include them again or use them again, because I think those stories really resonate with those elected officials and their staffs. I think, with OAC, we do a lot of this work. We can, if you identify people with obesity who are maybe a little bit, not 100% comfortable doing this, we have all kinds of training programs and advocacy programs to help get your patients ready to engage in these kind of conversations. So don't be hesitant to call on us. On the page here, you see all the kind of examples of different ways patients can be involved in OAC already, but I think one of the things that we do offer, and not a lot of people take advantage of it, is that, hey, I have a patient, they're lacking a little bit of confidence on having some of these conversations. Can you guide them? And we actually have resources and tools that actually teach people to actually have these conversations and how to share their story, and then how to understand the legislative process so they can be as effective as possible. And you see some examples of some folks doing that here. I think the other thing about this is that, living with obesity can be awfully lonely, even though it appears we are the majority now. Actually, we are the majority of people who have overweight or obesity in this country, but you always feel alone with your condition. So it does take a little bit more to convince somebody. As you know, many of you know, you have patients who will never be public about having bariatric surgery. They keep it private. Our hope is to break down that barrier so more people are willing to have that conversation, because that lets people with obesity know they're not alone, right? And there are options out there. And so that's why we exist, and that's why we're here. So I just wanted to leave you with a couple of resources. So we have resources. So if you have a patient who contacts you and comes to seminar or does the virtual seminar, and you find out that they can't or they don't have coverage, you should be referring to them to this obesityaction.org/access webpage, which actually walks them through different ways they can get involved to try to improve access to care. And there, that is everything from them sharing their stories with us to letting them know how to contact their elected officials, how to talk to their employers. And we even have a new video series. So I know everyone's gone from the written word to now video. And so we have a video series that consists of 8 different videos that talk about how they can be a further advocate for themselves. And you see the link for that here as well. But they're easy, they're short, they're 6 to 10 minutes each. And just to give you a preview, because I know he's on the call tonight, Walt Lindstrom and I are actually working on a project together with his new group, Priya Healthcare, that is looking at actually creating a similar video series on walking people how to better understand their insurance policy and understand how they could deal with some of the situations, even some that were mentioned earlier, like low BMI or revisions or coverage around those issues for the patient audience. So look for that coming in early 2021. So again, here's just my final recommendations. Use that patient voice no matter what, especially in your advocacy, but I think all throughout your practices and everything that you do. Really understand that every voice is different. So maybe a single voice isn't the right thing. We need to have a variety of voices. Actually, Lieutenant Governor Nungesser with his male story is somewhat rare, right? It's easier for us to find women who are willing to come forward and tell these stories. So it's important to have stories like his as well. Obviously we know that bias is the toughest issue your patients deal with. Many of them actually will probably admit to you personally that it's actually the stigma they face that's been harder to live with than actually the health consequences of their obesity. And so just try to keep up your empathy. And if you see an example of stigma out there, one way you can support your patients is just to address stigma head on, to challenge it, right? As you as a healthcare professional, if you see an article that's written that refers to obesity the wrong way, write a letter to the editor. It's more likely to get published, with your title and your institution listed than it is the everyday person. So please do that. And then just remind your patients that their voices do matter. And although this process is hard and it takes a long time, that they really should have confidence in our system. I know it does appear, everyone who's following the election stuff, that government is broken, right? But this process does work. It will work again, right? And so their voice and it does matter. A single person's story does matter. And if you can encourage them to engage in this process, we will all be better off in the end. So with that, Phil, I'll turn it back over to you, and we can go to the Q&A. So.
Okay, Joe, thanks so much. That was excellent. Let me just start with you, Joe. So what advice do you have, for the surgeons and all the healthcare providers on the call tonight to get our patients, engaged? Does it start with having them join OAC, and how arduous or how easy is that to do?
Yeah, so a couple things. I think first of all, to get your patients engaged, you simply have to ask, right? Many of your patients will do anything for you because you have remarkably changed their lives. Actually, the harder thing probably to do is the folks who haven't quite had treatment yet. Now, but you can take advantage of them, because when they find out they're being denied or excluded, you can work on that frustration and ask them to participate. Now, it is a heavy lift, right? I mean, it is scary. If any of you have gone and testified before a committee or even gone into some of these legislators' office, it can be quite intimidating, or the perception is that it's intimidating. So the other thing to do, of course, is to invite them to join the OAC. And there is a free membership in OAC, so they can join. There's no cost. They get all of our resources. They have access to our materials. If they want physical copies, which is less and less likely these days, but if they want physical copies, there's a small fee to be a member. But all the electronic stuff can be done for free, and all they have to do is go to obesityaction.org to join. And we start slowly. We start with educating them about obesity, and then we start building in the advocacy stuff to help build some confidence in them to be to help them understand the process and be willing to participate.
Yeah, thanks, Joe. And for all the surgeons and all the practices out there, I highly encourage you to try to engage your patients. One of the things that we do in our program, and Laura Boyer, our practice manager, can attest to this, is we use the OAC, the handouts. Post those handouts on your bulletin boards in your offices. When the patients come in for their visits, give them the handout. It's easy for them to join. It's free, and many of them will start taking on advocacy roles within OAC. There's plenty of room for that, right, Joe?
Absolutely. And I think, again, not everyone is ready at that moment, but it may be 3 months or 6 months or a year from now. And again, our need, maybe if Lieutenant Governor becomes Governor Nungesser and this moves through with no issue, there's still other issues. We're always going to need patient advocates, right? And there are other aspects of coverage that we'll need to tackle. So again, just build that confidence, continue to encourage, and then as you see patients, as they keep coming back and they're doing their follow-up care, it doesn't hurt to just give them that reminder. Hey, your story would make a real big difference. Why don't you publicly share that story, or go to OAC and share your story to be able to make a difference in the lives of others.
Great. Okay, well, we've got quite a few questions in the chat line that we can kind of go through. There also have been other questions that were submitted earlier that we can address. And Peter, please feel free, to jump in too if you have any other questions that you want to address also. But one question that came up earlier was, how can individual surgeons, make a difference? And I can't remember who said it initially. Maybe it was Joe Northrup. Yeah, that surgeons can influence their employers. And just to share a few examples, and maybe Joe, you can pop in here in a minute. I was fortunate. I was in Cleveland, to work with some other physicians to influence the Cleveland Clinic health plan to add bariatric surgery. This is over 15 years ago. You got to be persistent, but it is possible. And I'll just share another recent victory here at Our Lady of the Lake Hospital. And with the help of my colleagues, particularly Mark Hausman, who's been working on this for years, we approached the employers, and they've added bariatric surgery for the first time in history for the entire, FMOL healthcare system to be a benefit to the employees. So that is something that we can do as individuals. Joe, can you add to that in your experience?
Yeah, absolutely. So I think, everything comes down to, what we can do as individuals, and we can all make a difference. And sometimes we start with one person and we add 2 more and 3 more and 4 more. So I think if you're in a hospital that does not have coverage, I think there's always a leadership opportunity in your health system or your hospital to bring this to their attention. And my advice when people are always talking, when you're as a doctor talking about bariatric surgery coverage, stay away from the finances and all it pays for itself and how much money you get, how expensive healthcare is, and just talk about the result of the surgery. We're getting rid of diabetes, and we're getting rid of blood pressure, and we're extending lives, and that's what matters. And they know the finances, insurance companies, health systems, they know it way better than we do. So just stay away from it and approach things that way. And when I first moved to Ohio and worked in the Cincinnati area, they did not have coverage, and I advocated for it. And I said, this is a condition of my employment, is I want coverage for this health system. And it was about 6 or 8 months later when a woman had gastric bypass and resolved her diabetes after having it so long. And she went up to the hospital CEO, just a plan, and thanked him for covering surgery. And that hospital CEO called me to tell me that story. And that was very powerful for him. And he felt humbled by a patient just coming up and saying, thank you. To provide that coverage, and that made my life a lot easier to get things we needed for the practice. But advocate for yourself and advocate for your patients. Take the time to do it.
Yeah, every hospital system in Louisiana should cover this for their employees. And I think one can make the case that there is an ethical problem, especially for hospitals that have vibrant bariatric programs. And in many places, let's face it, these are pretty good profit centers or centers of margin, right? And so not to offer, evidence-based therapy for your employees says something about that organization, okay? So there should not be a hospital in Louisiana that doesn't cover this for their employees, in my opinion. So you guys go out there and talk to your leaders in your hospitals and make a difference.
I've actually advocated as a site surveyor for the college. I've actually advocated that condition of a accredited center being that the hospital employees are covered as well. So that hasn't gone anywhere, but I've brought that up a couple of times.
Yeah. Now, not to put our president on the spot here, Dr. Richardson, Austria does cover bariatric surgery for employees, right?
Yes, it certainly does. We do have a few $1,000 copay, but we have done it for a while. We did get embarrassed by one of our major insurers because they were covering it and we were not. They actually embarrassed us into it. So it is very important to kind of bring that up to your institution as a way to force them to pay for
it. It's too bad that it's embarrassment that motivates change. It should be that these are hospitals, these are nonprofit centers who are treating people that have illnesses. It should be altruism, right? That should be driving, but whatever it takes is what I say.
It is the right thing to do. It just seems so obvious.
Yeah. Now there's some questions for Dr. Bachhuber. Regarding Medicaid, Marcus, help us understand a little bit about some of these managed care organizations, because you showed us, I think, very reasonable coverage criteria for Medicaid. And even dropping the BMI to 30 for diabetes is ahead of the curve from many, commercial carriers. But my understanding is that some managed care organizations can add criteria, and I've seen adding 3 months, 6 month, 12-month diets on top of, the criteria that you have stated. So explain to us how that works.
Yeah, so I think that was one of the difficult things about the previous policy is that it was vague and nonspecific. And that kind of 3 attempts to lose weight, what does that mean? And then the plans interpret it to mean 3 months or, whatever of, kind of assigned a number to it that wasn't really the intent. But taking a step back, the managed care plans cannot be more restrictive than the state agencies. So there is no additional restrictions that can be put on. In fact, if you all experience any additional restrictions after January, please do let me know, and because that's something we take very seriously. And one thing I didn't call out specifically is we removed all mention of previous attempts. I mean, in a general sense, it's that they that weight loss would benefit them. We don't, because people, a lot of people, you all know that the people who come to you have been obese for years. So making them, jump through hoops for 6 months is just kicking the can down the road and not, and frankly, kind of disrespectful to patients. So we removed all that because that's really not, I think, where things should be now. So we focused on, the person has to have a multidisciplinary evaluation, has to be appropriate for surgery, has to benefit from surgery, has to be able to follow up, with the surgery. And that was really our focus. And the plans, we work with them very closely, and they can't be more restrictive than we are as the state agency.
Okay, well, thanks for sharing that, because I think a lot of us were confused about that. And so all of you surgeons and providers out there, again, after January, if you're finding that these managed care organizations are adding restrictions, you know where to go. Contact Dr. Bach-Huber, because we need to expose that. That's inappropriate. Also, Marcus, can you share with us a little bit more? And this, this may not be under your area, because I understand your policy, but can you share with us how the reimbursement is determined? Because I think that's one of the biggest hurdles for more patients, Medicaid patients, getting appropriate surgery in Louisiana, is that the reimbursement at the hospital and also to the provider, seems to be, fairly low, and therefore makes it difficult.
Yeah. So, going back, just, at the risk of telling folks things they already know, going back to the 1965 when Medicaid was created, it was always created to have lower reimbursement rates than Medicare, typically 60 to 80% of Medicare reimbursement. On a macro level, Louisiana is on par with its neighbors, but there are individual services that we reimburse higher than other states or reimburse lower than other states. But on a macro level, we're on par with our region, certainly. When a person gets a surgery as an inpatient, there's 2 bills. The hospital submits a bill, and then the physician submits a bill, and each has different charges and fees associated with it. So the inpatient stay, is Louisiana Medicaid pays per day, and then the physician payment for the procedure is a flat fee. There's a variety of other complex hospital financing mechanisms and logistics that go on that I'm not the expert on, but if I heard mention of reimbursement being an issue, and certainly we want to do everything we can to make sure that people have access. And so I would be more than willing to work with you or with the other members on this panel to take a deeper dive into reimbursement for bariatric surgery and see what the issues are.
Okay, well, that would be very much welcome. I think, hospitals have, they have a mission, they're a nonprofit, but they do have to stay afloat. And I think many are willing to accept, lower reimbursement, but to be able to at least, cover the cost or come close to it. And that would really open the door for many, many patients to benefit. Very good. Let's see. Let me ask if any of our other panelists have any questions that they want to put forth. Peter, do you specifically have any questions or comments you want to make to the other panelists?
I think Peter had to leave.
Oh, did he? Okay.
Yeah.
Okay. All right. I still see his name up there. Okay.
So Phil, this is Joe. I just want to throw just a comment out. We were talking about what individual surgeons could be doing right now. And I think one thing that one trend, disappointing trend, I think that I've noticed over the last few years is that we see a lot of surgical practices take no from a insurance company a little too easily. I know it is not pleasant, and times it feels like it's a waste of time when you do these peer-to-peers and you do some of these reviews, but I would challenge you to really go through that process again and really, like for many of you who've been doing this for a long time, like lots of us on this call have, go back to the early days where you continued to have those conversations and continue to pound on the medical directors. Now they might be able to may not be able to change their mind on that specific case, but I will tell you that some of the success that we've had, with some of that national data that we've seen and some of those national trends we've started to see, like the 3 and 6 months going away and things like that, that's all a legacy of us continuing to, have those conversations with as many people as possible. So I'd encourage you to go through that appeals process. And again, if you don't want to do it, then there's services out there that, we already mentioned Walter before. There's lots of people out there to do that kind of work that can help you with that process, but we have to appeal, right? Taking no the first time is foolish, right? I think we shouldn't take no so easily. So.
Yeah, Joe, thank you for mentioning that. Because, look, a lot of us, we're busy, and these appeals take our time. We have to sometimes schedule separate time with the medical director. We're not getting reimbursed for that, but it's the right thing to do. When you get to the point where you're on a peer-to-peer talking to another doctor, my experience is we win most of those. We win when you get to the point where you're talking to another doctor, we win those battles. Okay. But it is time consuming. And if you need help, I'm glad you mentioned Walt Lindstrom and there are others that can do this too. But if Bill will let me, I told Walter I'm going to invite him to talk to our organization, talk to surgeons and show them what we need to do in these letters and these appeals to win these over. And if we don't want to do it, there are people out there that can help us do it. So Walter, I know you're listening, so I'm coming after you if Bill will let me. Any other, Joe, any other thoughts, other trends that you're seeing that we in Louisiana could take lessons from?
Well, I think we kind of touched base on the low BMI trend is a great one. The getting rid of the 6-month diets. I feel like the worsening trends are some of the feedback we're getting from Blue Cross Blue Shield on that using the SAR data against us for the shutting down the centers based on lower confidence interval. That's going to be the next big push. And I think they're going to start trimming. It's almost like a tournament style. They're going to trim off 10% of us every year or two, and that's something we have to fight. The next biggest trend, as I mentioned, is revisions. I think we're going to have to start having some very specific, planned out approach how we tackle this chronic disease of obesity, and be very careful how we approach that, how we revise patients. Maybe everybody doesn't need a revision, get those criteria established. I think that's going to be the future.
That's a good point. Yeah. And look, I don't know of any surgical procedure that is perfect, nor any surgical procedure does not at some point need to be revised, whether it's a knee replacement or coronary artery bypass, or whatever. And so I think it behooves us to establish the criteria. And look, we all know there may be instances where we're doing revision, and is it really evidence-based? Does it really make a big difference? And we should look at that carefully. But there are certainly situations where an individual has not lost adequate amount of weight from a legitimate operation and needs to move on to the next, most effective procedure. That's very legitimate.
Yeah. And then I think the last thing I want to say is, if from access to care standpoint, my big thing is making sure people have coverage and have easy pathway to coverage, but we don't know about it if we don't know about it. So if, for us to take action and act on this, please let us know to the ASMBS Access to Care Committee. you can go through, Peter and Bill and Phil and bring things up to us that way, to your kind of representation of the Access to Care Committee. But anything, you were happy to help with anything, but you just need to let us know if you're having issues and difficult insurance, medical directors, companies, whatever, and we'll be happy to help.
Great. Thanks, Joe. Well, I see we're almost toward the end of our time. Do any of our other panelists have any other words of wisdom or final comments? If there's, I'll just ask, Bill, if there's enough interest, perhaps, a month or two from now, we could do another webinar on this topic. I'm new to Louisiana. I know there's lots of important issues going on, but to me, it seems that access to bariatric surgery should be one of our top priorities, and we can't talk about it enough. And there are quite a few people that we could tap into to sort of help us. So if there's interest, I would certainly be willing to work, with Peter and anybody else in the organization to have another webinar and keep pushing this issue forward.
Well, speaking for myself, I've loved this program, so I think I'd be a big advocate of moving forward with more.
Fantastic. Well, thank you all very much. Thanks to all of our listeners and all those who submitted very interesting, comments and questions. Thanks to all of our panelists. I personally learned a lot. Special thanks to Dr. Marcus Bachhuber for joining us and all the good work you're doing, Marcus, at Medicaid. It's really important stuff. And Lieutenant Governor, I think we found tremendous advocate folks that we should really utilize his services indeed. So thanks, everybody. Appreciate it. Have a great evening, and we'll all be in touch very soon. Good night.
Thanks, everyone.